So our Module 2 keynote speaker is Dr. Bill Bahnfleth. He is a returning speaker of the fourth time now? Fourth time, fantastic, and we appreciate you as always. He's roping in the critical topic of indoor air quality. The seasoned rodeo star grapples with the invisible forces that affect our daily lives. He is a professor of architectural engineering at Penn State, and he's an ASHRAE fellow, former ASHRAE president of society, not just of, the Illinois chapter like me. He is the recipient of the ASHRAE Presidential Certificate of Honor for his service as the chair of the ASHRAE Epidemic Task Force and his dedication to protecting the public during the COVID-19 pandemic. He is currently chair of the ASHRAE Environmental Health Committee and SSPC 241 for control of infectious aerosols, the committee responsible for developing ASHRAE Standard 241, for which he is the chair. I'll leave it to you, Bill. Thank you.
All right, well, thank you very much for the introduction, and I'm glad to be back. Always nice to come back to Illinois. I think I've said before that I grew up here, at least until I was a freshman in high school, so it always feels like coming home. And it's nice to be away from campus for a couple of days and giving a 1-hour lecture to a bunch of professionals instead of a 2-hour lecture to a bunch of undergraduates. But it's more or less the same topic because I'm teaching indoor air quality this semester. So what I want to do here with the time that I've got is to give you a fairly comprehensive introduction to a brand new ASHRAE standard, 241, control of infectious aerosols. Hopefully that won't be too dry. Anyone who's read an ASHRAE standard or any other code-intended standard knows that that's not good bedtime reading. If you want to absorb anything, I'll try to make it a little more interesting than that, and point out really some of the landmark concepts here and how this is not only a big step forward in terms of protecting building occupants from communicable airborne diseases, but also a model, I think, for what we do in the future with indoor air quality standards generally. And if you compare what I'm talking about with what was presented in the first two talks this afternoon, there really are a lot of connections, and I'm trying to, with what's left of my career, to get real building performance standards that account for not only energy and carbon, but also for the health and well-being of building occupants into actual use. And I think that's really one of the most important things that we can be doing. But I didn't budget 5 minutes for the first slide, so let's get going here. Why should we have a standard for airborne infection risk mitigation? Well, there are a lot of reasons for that. We know that airborne transmission of infections can be important. We have as many as 50,000 deaths per year from seasonal influenza, but that happens every year, and so we have tended to forget about it. We know that indoor environments contribute to risk of transmission. The way we design and operate buildings actually has an impact on infection rates. And it's not addressed in current standards, not only not addressed in codes, but not even in the standards that are partially referenced in the code. So there's a need for this. Another reason for doing this now is that we put a lot of effort into the ASHRAE Epidemic Task Force developing guidance that was widely used, but that was all in the form of recommendations. So this standard gives us an opportunity to take all of that experience and then to work it into the form of enforceable minimum requirements that could go into a building code. And while we would like to believe that ASHRAE Standard 62.1 and 62.2 would change, there's no guarantee of that, nor is there any guarantee how long that will take. Those are standards that tend to move fairly slowly. Oh, and yes, the White House asked us to do it, and that was a big factor. And I won't go through all of the things on this timeline, but essentially this standards development was initiated, if you go all the way back to when the White House started paying attention to COVID after about 2 years of the pandemic. So into the Biden administration, a year, the White House COVID-19 response team actually started talking about ventilation, the need for better building performance, and that culminated in March of 2022 with the program that they rolled out for air quality in buildings. And discussions continued into the fall of last year, and in November, Ashish Jha, the coordinator of the White House COVID team came to ASHRAE and said, we'd really like you to develop a standard and for pathogen control, and it'd be nice if you could do this by March. And we said, well, it would be nice if we could do it by March. We can't, but how about June, which is still about 1/10 of the time it generally takes to develop a standard. So the bottom line is that the ASHRAE board agreed to do this in December, and they made me the chair, and we had a committee that was approved and a title, purpose, and scope by the end of January. And then we started meeting at the end of February. So start the clock on developing the standard. It actually only took 116 days from the first meeting of the committee to the publication approval of the standard at the ASHRAE annual meeting in June in Tampa. So it was really quite a wild ride for everyone who was involved in that development. And I won't go through all of Ashish Jha's remarks when he came to Tampa to receive an award for his public service. He kindly said a few nice words about the standard that he had caused to be developed, and the bottom line is that he calls it one of the most important public health interventions that he's seen in years, if not decades, and we do think that this is an important new development. So what's the purpose of the standard? Very simply, to establish requirements for reducing risk of airborne disease transmission in buildings. And so this applies to all occupiable space, just like other standards, to existing buildings, to new buildings, to major renovations, to additions. And it covers, interestingly, going backwards in time to not only public buildings, non-residential buildings, but also to residences, and there are even some healthcare requirements here. And it's comprehensive, like other air quality standards: design, installation, commissioning, operation, and maintenance. You'll find all of those things in standards like 62.1. The really central concept of the standard is that it's all based on what we call equivalent clean airflow, which I'll explain. And I think that's really an important concept that eventually will affect all standards. What this is not is a new comprehensive IEQ standard. So it only applies to infection risk mitigation when it's needed. And a fine point for those who are concerned about how we do risk assessment, we based it on long-range exposure, so on the average concentration of infectious aerosols we'd be likely to find in a space, not what happens if you're the person who's sitting next to the asymptomatic infector, because that's a much more difficult thing to do, but that doesn't mean that it doesn't help there as well. So the main things that are covered in the standard, as in most, we start with definitions, and we have some prerequisites for compliance, and then the specification of the equivalent clean airflow rates. And if you're familiar with standard 62.1, you'll see this is fairly similar. The first thing you do is get for each space how much outdoor air do you need. Same thing, equivalent clean air. And then we have air distribution requirements that relate to natural ventilation and mixed mode ventilation, as well as mechanical. Big section on air cleaning, which is a very important key section of the standard. And then what we call assessment planning and implementation. And I think this is also an area where we've done more than most standards do in specifying the process as well as the requirements. Some O&M requirements, some special requirements for dwelling units, and then a lot of appendices. So that's what's there. The prerequisite is basically, and this fits with what I said about the scope limitations, that you have to have a building that complies with whatever the minimum acceptable air quality standard is. So whatever the building code you use is, says your ventilation rate should be and what filter efficiency should be, you need to comply with those requirements. So 62.1 or 2 or 170 for healthcare. And this is important because that actually is what sets the level of acceptable indoor air quality. And that's another project we need to work on, is raising that bar, but it's not one that we try to take on in this standard. So here are the definitions that I'll go through, and since I'm going to go through all of these in this order, I'm not going to read this list to you, but this is the list of key definitions that I'd like you to understand. And you've probably heard me talk before about long-range transmission. It's essentially transmission that isn't transmission that occurs in close proximity to someone who's infectious. And no one's has established a hard quantitative limit for close range, and no one ever will because there isn't one, but we generally think of it as being conversational distance, 1 meter to 2 meters. And the reason for that is that if you're actually in the exhaled plume of someone who's infected, then you can get a very large dose, and there's not much we can do about it with engineering control. So we're really looking at what happens out here, far from the infector, where we've got an ambient concentration that's kind of uniform. Right, so what's an infectious aerosol? It's an aerosol, particles in the air capable of remaining airborne for some period of time that contain pathogens. Early on in COVID, we were talking about, well, what can we control? 100 nanometer particles in the air. And the answer to that is who cares, because we don't have isolated viruses in the air. They're in particles that are formed by respiratory emissions that happen when you exhale, and that can be everything from 50 microns down to submicron, but these are generally much larger particles than viruses, and so we need to control those. There's a distribution of sizes for respiratory aerosols shown in the figure over here on the right-hand side. It tends to be about the same no matter what the activity is. Speaking or coughing, you can see these curves look the same. The difference is how many particles are emitted per event. So a cough produces a lot more particles than one exhalation. Within those particle distributions, the pathogens, whatever they are, bacteria, viruses, are also distributed non-uniformly. So it gets a little bit complex when you try to figure out how much you're actually removing. Air cleaning is really important in this standard because efficient compliance with the requirements is important. We understand, because there was pushback right from the beginning of the pandemic, that lots more outdoor air was a problem because it was going to cause more energy use. So we emphasize not promoting but enabling the use of alternatives to outdoor air as a way of controlling concentration. So an air cleaning system in this standard is any technology other than outdoor air that can reduce the concentration of infectious aerosols. So it can be fibrous filters, it can be germicidal ultraviolet light, it can be reactive species air cleaners, ionizers, photocatalytic oxidation, other oxidants. Want to be clear that the fact that they're potentially usable doesn't mean that they actually are. So the mention of these technologies in the standard is not an endorsement, and you'll see why when you see how we handled this. So I said that this isn't a minimum indoor air quality standard. It doesn't have to apply all the time. I suppose someone could choose to use it all the time, but we've actually said that these are requirements for what we call infection risk management mode. So a period of time when there should be a higher level of protection. If you've been watching the papers, COVID infection rates are coming up, hospitalizations are increasing. At some point, public health officials are going to pull the trigger and say, we need to do things again. We need to start wearing masks, or we need to do other things, distance. That's what we have in mind here, is that someone who's in a position to make an informed decision will decide that this is the time when we go to this. It might be 3 months out of the year for flu season. So who is the decision maker? We're not telling you who that is in this standard. It could be a public health official with the force of law, but it could be a building owner that decides, I want to give extra protection for my employees or my tenants at this point in time, or it could be the occupant. Remember, this applies to single-family residences, so it's your decision whether you want to do that. Why shouldn't we do it all the time? Because of the potential energy and operating costs that are associated. And the other reason is that there are a lot of times when the risk of infections are really quite low, and we're doing extreme things for nothing, really. So we think that this is the place to start, and we hope to add more nuance to that in the future. What I call this is introducing resilience into indoor air quality standards. So instead of having standards that only tell us what we do during normal operations, we're now adding a piece to that. Here's what you do when there's some sort of extreme event. And you can think of another kind of extreme event that might call for the same sort of measures. Anyone want to hazard a guess? Wildfire smoke, sure. And strangely, a lot of the same things that we do for infection risk mitigation help with wildfires as well if what we did was put better filtration into our building. So the building readiness plan is something that you might be familiar with from the Epidemic Task Force guidance, because we described this in that guidance. We've brought that idea directly into 241. The building readiness plan is a document that describes the assessment of the building and what was found, the result of a planning exercise to determine what should be done if additional protection is needed, and also addresses operational measures that should go on when there's a need to be in infection risk management mode. And now to the really interesting technical concept here, equivalent clean airflow. And the first thing is to just remember, when we say equivalent clean airflow, we're not talking about outdoor air. If that's all you remember, is it doesn't have to be outdoor air, that's a good start. The idea is that there is a quantity or a flow rate of air that's not contaminated that we could deliver to a space that would have the same effect as whatever we're doing in it. So we might have germicidal ultraviolet in a space. There's no air moving at all. We just have some lights on the walls, but they're having an effect on the infectious aerosol concentration. We may have an air cleaner, and we're circulating room air through it. No additional outdoor air. So we can represent any process like that in terms of an equivalent amount of dilution with uncontaminated air. So and this is really the fundamental concept. We determine what we need space by space and system by system, and then we figure out how to deliver it. So here's a really simple example of equivalent clean airflow. So let's suppose that I'm going to maintain some target concentration of a contaminant in a space by putting air through a filter that has a known efficiency. So there's some flow rate VRC, actual airflow, going through this filter. But if it doesn't have 100% efficiency, there's some equivalent clean airflow, VACS, that's going to be somewhat less. So we can imagine a process where there's a flow rate VACS into this space and exhausted at an equal rate, and it maintains the same concentration. We can show with very little math that for this air cleaner, the equivalent clean airflow is essentially the filter efficiency multiplied by the actual airflow. And we can do that for other controls as well. So how do we get these values space by space? So we did a risk assessment that I think is pretty unprecedented compared to anything that I've seen that's been done during the pandemic. And there are a lot of parameters that you have to fill in order to do a risk assessment. This slide shows a lot of them, and we could probably talk for an hour about what's on this slide, which I'm not going to do, but just a few examples. Are we talking about absolute risk? Are we going to reduce the risk of infection to X%? Or are we going to reduce risk relative to what it is without the control by Y%? What do we assume about the number of infectors in a space? Do we assume that there's always one, at least one? Or do we look at it probabilistically that we have maybe a 3% infection rate in the community and use that to come up with the number? So all of these things have to be filled in. You have to do it probabilistically. And in 241, we've used the Wells-Riley model, which is the most commonly used infection probability model, even though it's got lots of flaws to do this analysis. And the flow chart here on the right, which again I will not go through in detail, it's in the appendix to the standard, shows all of the boxes that have to be filled in to get to the equivalent clean airflow per person, which is that top box. So it was really quite an impressive effort, and there will be papers coming out describing it in more detail. So the required equivalent clean air depends on the space type, the number of people in it, and what's going on. We have a number of occupancy categories, as shown here, that cover a pretty wide range of facilities, including offices and schools, which are of high concern. Also, restaurants would fall in there. And there are 25 space types right now, so not like the 125 or so space types in 62.1, but that list can be expanded. The Equivalent clean airflow per person varies from 20 CFM per person to 90 CFM per person, which may give you some idea why A, you don't want to do it with outdoor air, and B, you may not want to do it all the time. If you decide that your design occupancy during infection risk management mode is the same as your normal occupancy, that'll give you a really big number. You do have the freedom to say, if we're in infection risk management mode, we're going to reduce the population. We're going to cohort people coming to work or going to school or something like that so that we have a lower total. So this is the table that's in the standard, and there's not really any more to say here except that we have those occupancy categories and the values. And you can see that for an office, we're looking at 30 CFM per person, in a classroom, 40 or 50, depending on how dense the population is. So how does this compare with standard 62.1 or with the new CDC 5 air change per hour recommendation? Well, generally speaking, of course, the equivalent clean air rates per person are much higher than 62.1. They were developed to give equal risk regardless of which of those space types you're in. So every space that's listed has the same risk per hour of occupancy, which means that it doesn't matter where you are. If you're somewhere 24 hours a day and every space is compliant, then you have the same risk, which is, I think, a really unique aspect of this. CDC recently recommended 5 equivalent air changes all the time. You can see in the table here what we actually get. So this is the standard 62.1 data in the upper table, which we won't go through. If you're familiar with the standard, you know that it's got a per person and per area amount. Let's go down to the bottom here and see what we get for an office, a classroom, and a restaurant per person using default occupant density. Oops, sorry about that. So office, 17 CFM per person per 62.1, with the ECAI for an office, that's 30. But that's only 1.1 air change per hour, so a lot less than 5. Classroom, 13 compared to 40. That's 10.5, so that's considerably more than 5. And for a restaurant, 10 CFM per person compared to 60 to get the same risk level, and that's 31.5 air changes per hour. So this is my answer to, well, is 241 equivalent to the CDC recommendation? It isn't, but I think I could also say that we've done a lot more to do this rigorously. So how do you meet the equivalent clean air target? You can use any combination of outdoor air above the minimum required and air cleaners of any kind that work. So it can be in-room air cleaners, it could be central filtration, it could be other technologies. And the reason that we've done this is to allow the user to do whatever best meets their goals, the cost targets that they have, the energy targets for the facility. The only limitations we have is that you have to meet the minimum outdoor airflow because that's the basic IAQ requirement. And we've decided to say that you're not going to get credit for central fibrous filters that are lower than MERV A 11. And we're requiring a MERV A rating starting in 2025 because that will give a better indication of the end-of-life performance of a filter. There's an article in the ASHRAE journal this month, as a matter of fact, that was written by Marwa Zatari, who was the leader of the risk assessment group that developed the standard, and some colleagues, that looks at the energy cost to show that we can actually do this without increasing the energy use of a building. The figure on the right, or the table on the right, it just shows that it's really pretty expensive to increase outdoor air depending on what climate zone you're in. These authors put together a number of examples in different climate zones. I'll just show one briefly that show the kinds of things that can be done. So this is a primary school, about 74,000 square feet with 1,478 occupants. And the figure on the right shows what happens if we apply the ventilation rate procedure, so the prescriptive approach in the ASHRAE standard, that's the main one that's used. the indoor air quality procedure as it's been revised in Standard 62, and what happens also if you add energy recovery ventilators to do that. So over on the right, we have sort of the most energy intensive case, which is meet the VRP and add 50%. And if we only have a MERV 7 filter in the system, what we see is that for a typical system, we're not even going to meet the 40 CFM per person requirement, although we've added 50% to the outdoor air. If we go to the ventilation rate procedure, the energy use goes down, but the equivalent clean air per person goes down, and we're still low. And the bottom line here is that without doing something with filtration, we wind up with systems that are energy efficient and meet Standard 62, but fall far short of the requirements. So if all we do is change in this system from MERV 7 to MERV 13, which has a much higher efficiency for infectious aerosols, now we see that for any of these solutions, VRP plus 50, it should be IAQP next, or no, that is VRP plus ERV, and then the indoor air quality procedure or the indoor air quality procedure with an energy recovery ventilator, we can get a really big reduction in the energy use of the system. And in all of these cases, we still meet the standard 241 requirements. So this is an opportunity to be creative in our development of solutions and to make use of this indoor air quality procedure, which has been greatly improved in the most recent version of Standard 62.1. We'd like to have more guidance than we have at this point on air distribution and natural ventilation, but when you've got basically 4 months to develop a standard, and this is an area where a lot of research is needed, we deferred a lot of things. So it's not that we didn't want to put some material in, but we decided it would be better to wait until the second publication to do that. So there are some classifications of air cleaning systems because there's concern about the airflow patterns that are created by air cleaners you bring into a space, but not much more than that. We've put off looking at things like ventilation effectiveness to the next version, and what's there on natural ventilation and mixed mode mostly comes from Standard 62.1. The really important piece in the requirements is air cleaning system effectiveness and safety testing. You know that it's appropriate to say at an event called Rodeo that it was kind of the Wild West for air cleaners during the first couple of years of the pandemic, and we wanted to do something about that. We had kind of an information vacuum, so we need to test air cleaners to know what their effectiveness is so we can determine how much they contribute to meeting the equivalent clean air budget, and we also have to know that they're safe. We're well aware that some air cleaners produce secondary contaminants or are contaminants themselves, and we need to limit the amount of them, particularly the oxidants and also to some extent UV. So we've got requirements for both that have never been in standards in the same way. So there's a big appendix on air cleaner testing, and whatever your technology is, if it is characterized according to the effectiveness criteria and passes the safety criteria, then you can use it. We don't rank technologies. We don't promote certain technologies. The goal here was to be technology agnostic and create a level playing field that had appropriate requirements for qualifying the use of these technologies. And some of the standards that are referenced in this part are listed here. Standard 52.2 of ASHRAE, which is for fibrous filters. 185.1 is a UV test standard. AHAM AC1 and AC5 are portable air cleaner standards. And there's ISO 16890, which is an equivalent of 52.2. We had to write a big normative appendix because 241's development sort of blew past a number of air cleaner test standards in development, like 185.3, and they weren't ready yet. But when they are ready, then they'll be brought in as requirements. We've had to classify air cleaning systems generically, not is it an ionizer or UV or something else. It's really more where is it in the system and how does it Act. And we've listed all of those things on this slide. Are they in-duct air cleaning systems that are single-pass devices, so we can characterize them that way? Or are we putting a device in a duct that's putting something into the space, ions or hydrogen peroxide or something else that will act there? We need a different kind of procedure for that, and that's why we have all of these different classes. For fibrous filters, because we have this issue that they collect particles according to the size distribution, but pathogens are distributed non-uniformly through the particle sizes, we had to come up with estimates of the overall effectiveness. And so there's a table in the standard that allows you to pick an efficiency by MERV value or by equivalent ISO value for different filters. And you can also use particle-based AHAM AC1 tests to come up with a clean air delivery rate, but you have to combine all three of them. There are three different tests for a portable particle filter according to AHAM. It's dust and pollen and smoke, and they all hit different size ranges. So we've got a weighted average of those that's used to do that. There are some requirements for air cleaning systems that act by inactivation, so in-duct ultraviolet systems and ultraviolet systems in the room. Again, I'll just say that these are referencing test procedures that are found in Appendix A or in some of the standards that I mentioned. So this normative Appendix A is an important one, determining air cleaning system effectiveness and safety. You need to use consensus standards to do it. If you don't have one, then you've got to come up with what is deemed to be an acceptable custom protocol. You need to do the same test conditions for both effectiveness and safety testing. Third-party laboratories that are ISO IEC 17025-25 or equivalent certified. The test chamber volume is specified at least 800 cubic feet. Why is that important? A lot of air cleaner tests by manufacturers were done like 100 cubic foot, 10 cubic foot chambers, and they were claiming really high inactivation rates, but the clean air delivery rate that was associated with that was really small. So it has to be a reasonably room-sized kind of chamber. And the microorganism tests all have to be done with MS2 microphage, which is just a way of having a standardized challenge for all of them. So when we do chamber testing, which is really the hardest kind to do, we have to account for the natural loss that occurs when we put an aerosol into the air, as well as the performance of the air cleaning system. So you have to run two tests, one with no air cleaner, and you watch how it decays, and one with the air cleaner and watch how it decays. And by comparing the two, we can determine what the air cleaner actually did. I mean, this was one of the problems with manufacturers saying that they had a technology that would remove 99.9% of the active viruses in 3 hours. Well, if you turned it off, you'd probably have lost 85 or 90% in 3 hours because most of the particles would have settled out. And that's why we're focusing on clean air delivery here and not on how long does it take for them to go away, because they will go away. So this is what those tests look like. You can see here on the left-hand figure, the raw data on linear coordinates, air cleaner on, after we've seated the chamber, and then we seat it again and do air cleaner off. And if we plot these results on semi-log coordinates, we get slopes of these lines that are the removal rates for no air cleaner, and we can just take the difference between the two. So that's performance. Safety testing requirements. We have 3 chemical analytes that have to be tested for: formaldehyde, ozone, and particle generation. Those are the 3 main ones to be concerned about. Sound levels of portable air cleaners have to be reported. There's no regulation of them, but there are a lot of air cleaners on the market that will operate at above 60 dBA. some above 70, and if you make a Corsi-Rosenthal box, your box fan might be 90 or higher on its high speed. And what happens when you have a noisy fan? You turn it down. So the user of the standard should be aware of what fan speeds are going to result in acceptable noise levels. There are special requirements for UV, for combustion byproducts. If you have air cleaners that actually use combustion, which some do, and the manufacturer has to certify that these tests have been done. All right, so that's the requirements. Those are all the things that have to be satisfied. The last piece here is about assessment, planning, and implementation, and essentially this is bringing our ideas about commissioning into the world of infection risk mitigation. And the end of the process is the development of a building readiness plan. The assessment piece starts with determining the condition of all of the systems, and we know that if you look at a lot of buildings, you're going to find a lot of buildings that aren't even meeting their basic design requirements, a lot of maintenance that's required. So we need to identify things that need to be brought up just to their baseline, and the assessment will also determine the system as it is, if it's an existing building, what does it provide in terms of the total clean air requirement, and then you can compare that with the requirement based on Section 5 of this standard to determine how much more you have to do. That's really the gist of the whole process, is to bring the system up to where it should be and enhance it as much as it needs to be. And there are a lot of supporting information items that are in the standard to help you do this effectively. There are checklists on the commissioning items in Appendix B. There's an appendix on doing in-place particle removal testing. If you want to actually test a space like this to determine how well particles are being removed, there's an appendix on how to do that. There's a template for the building readiness plan. All of those are in appendices. And then there are 3 online references. One is an equivalent outdoor air calculator, and there's a document on how to assess ERVs to determine whether they're safe, and another on reentry of contaminated air. So this is the sort of things you'd have to do for an existing building, and it'll be familiar to anyone who does this kind of work. Go to the site and gather data, inventory what's there. If you have separation spaces or the need for separation spaces, by which I mean a place to isolate someone who's infected, which you might do in a healthcare facility or in a residential building, identify those, and then check the ventilation and a lot of other HVAC control, HVAC components and control strategies. And this just continues on with existing buildings to determine the target and determine whether you're meeting it or not, and then to do the planning to determine what should be changed. New building or a renovation, you're starting without that baseline that you need to assess, so this is more checking the design documents and developing the things that you would develop for a new building. This is the top page of the equivalent clean air calculator. This is actually the descendant of the equivalent outdoor air calculator that we developed as part of the epidemic task force effort. It was a spreadsheet that was meant to help determine the consequences of putting different controls into your building. And this is what the main spreadsheet page actually looks like. Don't expect that you'll be able to necessarily read all of those items down the left-hand side, but some of these are provided numbers, some of them are user-entered numbers, and each column going to the right is another option. So we start with the existing building, and then you can develop different alternatives where you try out different things. In-room air cleaners, UV, change the rating of the filters in your air handling unit. And at the bottom, you'll get the resulting equivalent clean air per person, which is what you're trying to achieve. It'll tell you whether you passed or failed. And you can combine this with other analyses, like how much is this going to cost and how much energy does it use, to decide which of these you're going to use. I think in the future, we hope to add some of those other considerations in. So that's assessment, planning, and implementation. In operations, we have really two kinds of requirements. One I would call things that relate to preparation, to being ready, and other things that actually relate to the control of systems. So on the preparation side, having a building readiness plan that's up to date on site is important. Having essential supplies stocked, so if you're going to need a lot of filters, or if you're going to need to have air cleaners that you're going to bring out, if you don't want to have them out all the time, those need to be available. We ran into a lot of supply chain problems during the beginning of the pandemic. Who was making most of the masks that were used in the US at the beginning of the pandemic? China. The first masks that I got when COVID started were sent to me by a friend of mine at Tsinghua. He said, you know, I understand you've got a mask shortage, would you like some? And he sent me about 1,000 masks. They were surgical masks, but you know, it's the thought that counts. And we had a problem with filters also. You know, there was a run on MERV 13 filters when ASHRAE said that would be a good idea if you upgraded to MERV 13. So that's the importance there. We also need to have operators trained on the special operating modes. We need to have communication with occupants about what we're doing. So all of that stuff has to be in place, and then these operating modes should be defined and in the control system so that we can make quick, graceful transitions. As far as controls during IRMM, we have not ventured into fiddling with temperature and humidity set points. Just keep them where they're supposed to be by design. Operating schedules, a couple of important things. One, system should be on whenever there are people in a building. And secondly, because you'll lose whatever the system is providing in the way of ECA, equivalent clean air. When you turn the fan off, if you have fan cycling, you can't do that. So you need to have systems capable of running with continuous fan operation. Actually, I do that at home, right? I have a typical DX system at home. I could put into auto mode and the fan would go on and off whether cooling was needed or not. I just run the fan all the time because I've got MERV 13 filters in my air handling unit, and it cleans the air all the time. As far as airflow controls, you'll be glad to hear that there's no longer a flushing requirement if you're complying with the standard. Why? Because if you meet the equivalent clean air requirements of the standard, you already got a low level of risk, so you really don't have to worry about clearing the air as we did early in the pandemic. And you need to look carefully at any variable fan operation that you have if you've got demand control ventilation and variable air volume. There's not any specific requirements at this point, but you need to consider it because that can have a big effect on how your system is working. And this slide discusses in particular the requirements for looking at delivered equivalent clean air when you have variable fan operation. So you simply need to look at what your plan is and use the right airflow. If you're deactivating DCV, then your design outdoor airflow is what you should assume for the system. But if it's activated, then you have to base your calculations on the set point for minimum DCV. And the same thing with variable air volume. What is the minimum flow? And you can take those values and put them into the calculator to do your analysis. Maintenance is also touched on here, and the main things that are incorporated in 241 are first of all, some maintenance items that are critical to infection risk mitigation need to happen more frequently. Standard 62.1 says you have to check the outdoor air at least every 5 years. That's not really good enough. It needs to be checked every year if you're going to be operating, or within a year if you're operating in infection risk mitigation mode. The other thing that we've added are a few requirements for special technologies that are not addressed in 62.1 or 2 because it doesn't address infection risk. So use of in-room air cleaners, we've got requirements for them, for ultraviolet, and for others as well. And getting to the end here, for dwelling units, the main reason that we covered them as a separate category is that you may have infected people at home. So we have requirements that you have a separation of area defined for someone who's ill, which could just mean a room with a door that can close. We didn't address depressurization at this point. And so you have to have some place to put that person, and you should have the same equivalent clean airflow in the separation zone as you have in a patient room in a healthcare facility. If you have vulnerable occupants, then the whole dwelling unit should be treated that way with a higher equivalent clean airflow delivered. So that's the main thing here. And other things that are important in some contexts, it's good to have lids on toilets and have them down when you flush them because that's an aerosol generator, and keep water in plumbing traps. I don't think that's a big problem in a lot of US buildings, but there are a lot of super tall residential buildings in other countries where it's a frequent problem to have dry traps, and those become conduits to transmit infection from one unit to another. So that is pretty much it. I want to do a recap here and a few final thoughts. I know when we go through it requirement by requirement, and if you haven't seen this before, it can be a lot to absorb, but I've tried to put the whole thing on one slide here. Is think of this as a process of determining how to make your facility safer. So now we're kind of inverting it and starting with the assessment, planning, and implementation process. So assess, determine the condition of the systems and the equivalent clean air that it's delivering. Determine what you need to provide according to the standard. And if there's a difference between those two numbers and it's a deficit, then that's what you're going to have to determine how to provide. So the fourth step is doing the design and analysis to determine how to make up that difference. And then all of this goes into the building readiness plan so that it's all documented. And then, very importantly, if you identified maintenance items, go around and do them. Maintenance is really so critical, and this is the thing about these building performance standards that I think makes it important that we bring them over into IAQ as well, is that it doesn't matter how well a system is designed if it's not maintained. So we need checks and requirements periodically so that we know that systems are doing what they're supposed to do. And then we implement the upgrades if we need them. So that's it in a nutshell. The broader implications, I think equivalent clean airflow, and I know equivalent clean airflow is a concept that could be extended to other aspects of air quality. We have particles that we're concerned about, we have gas phase air contaminants, and we have pathogens. And we can define for any system what its equivalent clean airflow is relative to any of those. So we're going to wind up really with 3 different numbers for any facility. Why would they be different? Well, if I had put UV in this space to get up to where I wanted to be with pathogen control, that doesn't do anything for particles or gases. And that's why we get different numbers. So it's an important concept from that point of view. It could permeate all of our standards, and it's the only approach that I've ever seen that brings together all of the different controls into one number. So there's an equivalence between them that allows you to optimize. A standard that says, well, you have to have so much outdoor air and a filter of this efficiency really does not facilitate doing that. Infection risk management mode, as we've already touched on, brings resilience into these standards, and it's really needed not just for infection risk, but also for wildfires and other events that might be periodic and acute. And then the air cleaner testing requirements. I don't think there's really a good path to a high IAQ, low energy, low carbon future without alternatives to ventilation. It's just not something that's going to work. If we're going to condition that air when we bring it in. Of course, if we just have free running buildings with no heating or cooling, that's a different matter, but most of us wouldn't want to be in those. So I think there are a lot of things here that may change standards in the future. And as far as this standard in the future, right now we're doing a lot of communication, like me here talking to you and a lot of other groups. We're working on pilot testing programs. We've been talking with the GSA and others about doing a test to get feedback on how it's working that would help us modify it. This is a non-ANSI standard because we needed to cut that corner to get it done in the time frame that we were asked to do it in. and we'll be looking at getting it referenced in the 62s and adopted in codes, but all of that is an ongoing project. As far as things we might actually change with the standard, a performance path instead of this prescriptive table of ECAI values. Those ECAI values were developed for a specific level of personal risk. They were developed based on SARS-CoV-2 characteristics as far as infectiousness and other parameters that might be set by the user, like community infection rate. So if we want to look at what we do during a measles outbreak in schools or a bad flu year, we really ought to be able to calculate different targets and modulate how we operate buildings. We want to do more with energy use requirements, at least documenting the demand impact of IRMM, add more space types to the prescriptive table. A lot of changes should be coming, enhancements on air distribution. And as our understanding of how to test air cleaners for safety and effectiveness improves, we'll be modifying the standard in that way too, but don't expect a full new reissue of it probably for 2 or 3 years. We have a lot of work to do to get there. So that's all I have, and I'll be happy to take questions. And the URL there at the bottom is a link to the standard on the ASHRAE website, and also to some related information, some articles that talk about it, and a few presentations and podcasts as well. So thank you very much.
Thank you, Bill. Excellent presentation. I'm sure you all have many questions, and we have a few minutes to field a few of those. So can I get who'd like to go first? Anyone? Any questions at all? John. Sorry.
We were called in at a school district to test bipolar ionization in about, I'd say, 300 or 400 classrooms. Is your standard going to delve into that also? And what do we use as far as particulate levels that we should be aiming for to determine these are working properly? And how does that affect the calculations for the equivalent clean air flow?
Right. So in this first version of the standard, there's a requirement to do a chamber test with MS2 as the agent, regardless of what the air cleaner is. If you're putting ions, or if you've got photocatalytic oxidation that's putting hydroxyl radicals or low levels of hydrogen peroxide, or if you're spritzing triethylene glycol into the air, it doesn't matter. The effectiveness test is, when you follow that protocol, what is the removal rate, right? So that's the effectiveness piece. And then every technology has to be tested for formaldehyde, ozone, and particle generation in the same chamber under the same conditions. So you could, in principle, use bipolar ionization, but let's see what happens when you test it under those conditions in a third-party lab. If it doesn't work very well, and some of these technologies haven't worked very well when they've been independently tested, then who's going to want to use it?
You're saying the key thing is the third-party test.
And so what we've tried to do is establish the rules for qualifying, not to pick winners. Because that's a good way to wind up in legal action. It's just really not the right approach. We ought to be able to specify the test conditions that will determine whether something is, or how well it works, and whether it's safe.
Okay, thank you.
Thank you for your first question, John. I do have 2 copies of 241 standard that will be given to participants asking questions. Only non-cyclones, though, unfortunately.
Now there will be no more questions.
Yeah.
Thanks a lot.
$100 value. I believe John is awarded our first.
I'd agree. Following up on John, Bill, has there been any of this independent lab testing happening? Is there lots of results out there since some of this has come out just pretty recently? Maybe not, but
yeah, actually there has been, of course. Brett Stevens at IIT has done some of his own testing, but a major manufacturer, I guess this is an ASHRAE meeting, so I can say Train, tested both bipolar ionization and dry hydrogen peroxide, and issued some really nice reports on it that I think are still available online. That's the kind of testing, and Boeing tested bipolar ionization in aircraft too. And so, yes, there is that kind of evidence, but now, you've actually got to provide the evidence of complying with these tests to play if you want to meet this standard.
Gotcha. All right. Mickey, Emmy, you had questions? Sure.
Yes. Can you define what MS2 is? That's the first I've heard of it.
It's a phage.
Is it dangerous?
What?
Is it?
No, it isn't. That's one reason they use it. It's just it's a very well characterized microorganism, and it's not something we're concerned about from a health point of view. It's just used all the time in lab work because it's relatively easy to measure. It's also fairly resistant to a lot of controls, like to UV. So you get a good signal from using it.
Cool. And then another question I had was at the beginning you mentioned, I just want to make sure I understood correctly, the size of a virus is much, much smaller than the size of a aerosol, and that makes it easier to control because we're dealing with limiting aerosol transmission and not just like pure viruses flying around. Is that right?
Generally speaking, the larger particle is, the easier it is to remove it from the air. And so there was a lot of, first there was a lot of misunderstanding about filter standards. People would say, well, the HEPA filters they remove 99.97% of particles down to 0.3 microns. But actually, that 0.3 microns is more like the most penetrating particle size. When you keep going to smaller particle sizes, because of diffusional capture, the efficiency of even a moderate MERV filter goes up. So, that's one concern, is that people were misunderstanding what filter ratings mean. But yes, the smaller particles can be tougher to remove in some size ranges, but it isn't what we need to be worried about, because the particle that's carrying them, it may be an order of magnitude, 2 orders of magnitude larger. And we actually have data on how filters work for 1 micron particles, 3 micron particles, 5 micron particles. Even the HVAC filter standard 52.2 tests down to 0.3 microns, which again is kind of the bottom of the curve.
Okay, so if a virus is on the nanometer scale, but it's riding in a aerosol particle that's larger and caught by a filter, then that virus is taken care of.
Yeah, the filter doesn't care what's in the particle. It only cares how, the removal is based on how big it is.
I want to do one last non-cyclone question, and we can always table more for a happy hour, of course.
Question, what type of training will ASHRAE develop, and will there eventually be a certification for the application of that standard?
Yeah, certification, I don't know if ASHRAE would develop a certification for that. We'll see, but right now we're working on a lot of educational programs. I mean, this is kind of the prototype of our presentation for general technical audience, but we're already planning to do 2 3-hour courses at the ASHRAE winter meeting, which happens to be right here at McCormick Place. So there'll be a 3-hour expanded version of what I did that's just on background and the requirements. And then the second 3 hours will be done by Wade Conlon and Megan McNulty, who are both practitioners, and that's going to be on application. So that's going to be in the direction of how do you actually apply this to a building, and I think there'll be examples, maybe even bring your own project, and we'll talk about it. So we're going in that direction. Whether there'll be certification, I'm not sure, but I have heard that AIHA is forming a group to look at 241 and how to implement it, and I think something like that may come out of that effort as well.
Great. Any other questions? I think, yeah. Oliver, you may have this already, but I'll give it to you. All right, well, thank you all so much. I think we're at about the end of our time here for this this session. So thank you so much, Bill. I want to
Thank you.
also congratulate you on not being your first rodeo.
Thank you.
You also get one of these, so thank you all so much.
Right. Thank you.